Thank you.
Thank you, my lady. Professor McBride, I was about to ask you to go on to another document. It's one that we've had up before, and I'm sure one that you're very familiar with, INQ 83097. This is the report from Northern Ireland Office titled COVID-19 Situation Report Number 1, dated the 12th of March 2020. And if we go to page 2, please, we can see there the case numbers for England, 491, and then looking at Northern Ireland, 20 as of 11th of March 2020, and sadly, 10 deaths. We can see underneath there that Cobra M today took the decision to move from contain to delay. In practice, this initially means a change the advice to those suffering mild symptoms to not phone 111, to self-isolate at home for 7 days. This was communicated today. And it goes on in terms of isolation requirements. Looking at that and the case numbers as of 11th of March, would you accept that the case numbers in Northern Ireland were low by comparison?
Well, and that is the number of confirmed cases.
Yes.
Northern Ireland has a smaller population than other parts of the United Kingdom. I think that what that figure doesn't tell us is the number of unconfirmed cases that there were at that time, given the fact that there was in all likelihood sustained community transmission.
Northern Ireland was a different epidemiological unit. Would you agree with that?
To an extent. I think that Northern Ireland shared a land border with the Republic of Ireland, and there was free movement of people between the rest of the United Kingdom and Northern Ireland.
Why did you advise that testing and contact tracing is paused?
There was insufficient testing capacity at that time to continue community testing. We were at that stage still in the middle of the winter-spring respiratory virus season. There were significant numbers of people with respiratory symptoms. It was no longer wise or prudent to assume that only those with symptoms who were returning from other countries would have COVID. And at that time, it was necessary, if we'd had the testing capacity, to expand the testing to everyone with symptoms. Now, notwithstanding the fact that, unfortunately, the symptoms of COVID were very non-specific, and we simply didn't have the we didn't have the testing capacity at that stage. And what tests we did have, we needed to prioritise for those in receipt of clinical care, either at that time or those who were about to become unwell and require clinical care.
Now, does it follow that the strategy in England for where it may have been epidemiologically different to that of Northern Ireland, with the caveats that you have given, would you accept that that did not necessarily fit Northern Ireland at this stage of the pandemic, so around the 11th of March 2020?
No, I mean, I don't accept that. At that stage, there was evidence of community transmission in the Republic of Ireland. So we were very mindful of the fact that was the case. It was extremely unlikely, in my view, from a professional perspective, that this virus was behaving anywhere differently in the rest of the United Kingdom compared to Northern Ireland or the Republic of Ireland. What we didn't know at that time was the extent of community transmission. And in my view, it would have been extremely unwise to seek to advise ministers that it was sensible to remain in the contained phase when we already knew that we had community transmission and that community transmission was likely to increase exponentially.
We have within the documents that's been provided to you, an independent SAGE report. It's INQ 249693. It's dated the 12th of May 2020. And if we go to page 6, paragraph 9, relatively small, but it says, thank you, managing the risk of importing cases from other countries with consequent high risk of transmission is vital. This should be introduced as soon as possible, treating Great Britain and the island of Ireland as distinct health territories. Pausing there, do you accept that? Would you agree with that?
Not entirely. I think that there were differences in the epidemiology between the two islands, and that at times the epidemiology and trajectory of the pandemic in Northern Ireland was more similar to that in the Republic of Ireland than it was to the rest of the United Kingdom. There are other times when that was not the case. I think that the learning point for me from this, as I've indicated previously, was there needed to be greater harmonisation of policy approaches across the islands, and as I summarised before, a five-nation, two-island approach. Again, there was the common travel area, there was freedom of movement of individuals at key points throughout the pandemic. There were clearly, apart from the health considerations, there were many other considerations which ministers would have reflected upon, which are out with my remit in terms of the societal and economic consequences, the supply issues which such an approach may have resulted in. But obviously those were matters which were beyond my remit to provide advice on.
I want to come back and touch upon that in another context. Thank you. We can take that document down. And without wishing or wanting to invite you to enter into the fray, but the evidence that this inquiry has heard and received, and I'm going to ask, please, that the statement of Baroness Foster, INQ 475070, is brought up. Just so that we can see it in writing rather than me trying to summarise or paraphrase the evidence. Page 23, thank you. Paragraph 109. Maybe it should be paragraph 109, forgive me. Thank you. Baroness Foster says here, I believe the most significant catalyst for the increased rates of COVID-19 in Northern Ireland in August 2020 was a lack of compliance driven primarily by the actions of the Deputy First Minister and other members of Sinn Féin at the funeral of Bobby Storey on the 30th of June 2020. The public had complied with onerous restrictions from March to the end of June on the basis of a level of public confidence in the measures that we had introduced to try to keep people safe. She then goes on to say that the very public breaking of trust, and people questioned why they were sacrificing their personal life and relationships when people at the highest level of authority in Northern Ireland didn't. So at the top of that paragraph, Baroness Foster is saying, I believe that the most significant catalyst for the increased rates in Northern Ireland in late August 2020 was a lack of compliance. And I've given you some further context there. Can you help us at all with whether or not there is any evidence to support that?
I mean, from a purely scientific and public health perspective, I'm not aware of any evidence that that's the case. I think the major driver of the increase in cases throughout that summer, into September, into October, were the relaxations in the non-pharmaceutical measures which had been agreed by the executive. That's what led to the increase in transmission. There was more mixing, there was more people coming together in a range of environments, and that led to an increase in the pandemic.
Just in a similar vein and see if you can help us with this. Had testing not paused in Northern Ireland on the 12th of March of 2020, is it likely that more positive cases would have been picked up, positive cases identified?
That is undoubtedly the case.
And does it follow that the spread of the virus for Northern Ireland after March 2020 is likely to have been constrained if testing hadn't been paused?
Sorry, could you repeat the question?
Perhaps I'll simplify it, that might be easier. Does it follow, do you accept that if contact tracing, if testing, hadn't been paused, that the spread of the virus would have been less?
We shifted approaches. I mean, the policy position then shifted from testing everyone with symptoms to accepting we didn't have enough tests to test everyone with symptoms, given that there was community transmission, although the extent of that we didn't know,
yes,
to then population measures. So at that stage, everyone was with symptoms of any nature was advised to stay at home.
I appreciate that that's the rationale and the reasoning, and that's important context. But just in terms of likelihood and what the impact of that, could you help us?
I think that would be mere conjecture on my part. I mean, the fact of the matter was we did not have the test to continue community testing, and to seek to do that when we needed to reprioritise those tests and not take the decision to move to wider population measures, such as individuals with symptoms staying at home, their household contacts staying at home, work from home, avoiding unnecessary travel, avoiding pubs, theatres, etc. Had we not moved to those measures, I think the consequences, given the limitation in testing at the time, would have been much greater.
And I think you've touched upon this already, and I said I would return back to it. But do you have, I want to give you an opportunity to say whether you have any reflections on the decisions of the department with regard to pausing testing and contact tracing in March 2020?
Yeah, I mean, I think it's probably one of the most important lessons learned from the pandemic, which is that we had insufficient tests and an inability to scale up testing capacity as quickly as we needed. As a result, difficult policy choices were made by ministers, and undoubtedly, had we had more testing capacity, we would have continued community testing and contact tracing for longer, and we, on all likelihood, would have been able to remain in the containment phase for a longer period of time. Sadly, that wasn't the case. And I think for the future, we need to ensure that that diagnostic capacity and capability is built in as contingency. And if it can't be built in as contingency because of budgetary constraints or competing priorities, that we retain the knowledge and wherewithal to how we would surge that very quickly. And as we did in Northern Ireland, that will mean working in partnership with academic institutions and with the commercial sector, which we did through the Scientific Advisory Consortium, and that was hugely successful in building Pillar 1 capacity within the province.
Can I just follow up? You've been frank enough to admit the decision to pause testing was resource-driven. You just didn't have the capacity. Do you think the governments of the United Kingdom were frank enough with the public when the community testing was ended?
It's very difficult for me to cast my mind back in terms of the communication and messaging at that time, because many of us we weren't at home watching the television. We were working at such a pace. I think that the one message, and I've reflected this in my own reflections and learning from the pandemic, is that, as Councillor said earlier, that in any crisis and emergency, trust is the most important thing. It's hard to maintain and it's easily lost. And when you lose that trust, then it's very difficult to convince the population to have a test, to contact trace, or to comply with the advice around isolation. So all the behavioural science and the science that we were seeing at the time was you've got to be open and honest with the public. You've got to tell them what you know, what you don't know, and they need to understand why you're asking them to do the things you're asking them to do. I think we tried hard to do that. I'm not certain that we were successful in doing that. My impression was, certainly in Northern Ireland, that we were very open and honest in terms of what we knew, what we didn't, and the limitations in testing capacity and why we were making some of the decisions that we were making. Otherwise, people were not going to come with us. And I think that's particularly important when you're depending on people doing the right thing, even when doing that right thing has had huge consequences for them personally.
Thank you.
Thank you very much. I just have a few more areas that I'd like to deal with, which I might just canter through, if I may, because I really would like to ask you about inequalities and any further reflections in terms of recommendations that you might have for a future pandemic. But before I turn to those two topics, notifying the executive on the 16th of March, we've heard evidence that the decision to pause testing and contact tracing was communicated to the executive on the 16th of March and not sooner. Do you accept that?
I mean, that's the factual position. The First Minister, Deputy First Minister and the Health Minister were at the meeting where the decision was made, but I think it was probably first discussed with other ministers at that meeting on the 16th of March.
Sorry, I'm not sure that's exactly what I've heard from certainly Mr. Neil this morning. You say the First Minister and the Deputy First Minister were present with the Health Minister when the decision to pause community testing was taken.
At Cobra on the 12th of March.
But they didn't understand that was what the decision was.
Okay, I can't.
You thought it was clear?
I thought it was clear, and it was, clearly reflected in the minutes of the Cobra meeting.
Thank you.
What was it perhaps clearer to you because of your background, the medical background, and information that you might have received prior to that Cobra meeting?
I think, in fairness to ministers in Northern Ireland, they had only returned. The executive had only been established on the 11th of January after a hiatus of 3 years. The First Minister and Deputy First Minister attended their first Cobra meeting on the 2nd of March. The Health Minister and I had been immersed in this for many months at that stage. So I think it is understandable that the First Minister and Deputy First Minister may not have been across the detail, but obviously they were relying on officials to brief them on that detail. And those officials obviously included myself.
And so just following on from that then, should the decision to limit testing to hospital settings have been raised with the executive before the 16th of March?
Again, that would have been a matter for the Minister to decide and other ministers to determine, not a matter for myself. I mean, certainly the Health Minister had been briefing the executive from the 3rd of February every week at executive meetings. And he'd made, at that time, 7 statements, both oral and written, to the Assembly. So, and we as a department were extensively briefing other departments in terms of the preparation that was required for potentially what lay ahead.
We've heard from the First Minister this morning that decision led to better decisions being made, and sometimes being described as tensions that followed, and that there were concerns about transparency following and flowing from that. Do you have any insight that you can offer as to what the trajectory of meetings were after that? Does it fall
that discussion, not that
discussion.
Decision. That discussion
Yes.
led to better decision making.
I mean, I had not previously, until that point, attended executive meetings. My first executive meeting was the 2nd of March. I did attend a significant number of executive meetings thereafter. My own view and experience was that the professional advice that myself and the Chief Scientific Advisor was listened to respectfully. It was taken on board. Ministers were juggling a number of other priorities, not just the health implications, but the wider societal and economic implications. And yes, there was at times robust discussion. I think that was healthy because these were decisions that were impacting on people's everyday lives. And I think that the people of Northern Ireland benefited from having a restored executive, which was actually making decisions for them at one of the most challenging times possible.
Thank you. In fairness to you, the inquiry has received evidence from Baroness Foster in her witness statement. I don't think I need to take it to you. I think you may be familiar with the passage. It's regarding a decision where she says the use of resources to combat COVID-19 rather than count, self-isolate for 7 days first rather than testing. To provide you with some context, it's discussions following on the 16th of March, and that's a handwritten note that's provided. Is that something that you recognise or can remember?
I don't remember the comment, and I didn't see the handwritten note prior to preparation for giving evidence to the various modules of this inquiry. My only reflection is that they are handwritten notes, and those were quite fast-moving conversations. And again, I don't know and can't account for the complete accuracy of the recorded handwritten note. That's not a criticism. It's just that there were complex issues being discussed. So I can't attest to how accurate or otherwise it is.
Right. Thank you. Let me turn then, please, to one matter that I just want to ask you about for clarification purposes. It's been attributed to you, and I think we should have the document up for this. It's Baroness Foster's witness statement, INQ 475070, page 25, paragraph 101. And it's regarding the 30th of March 2020 meeting, where it says the CMO responded to these concerns, stating, inter alia, that Department of Health were rapidly ramping up testing capability, shortage of testing agents, 800 a day, Republic of Ireland, and it goes on to say Republic of Ireland with 1,500 tests per day. The CMO further stated, delay phase, advice to anyone who is symptomatic, contact tracing sustained during containment phase, next phase of epidemic, increased testing. Numbers at this juncture, too many numbers, pressures. It goes on to say the Executive Committee were therefore effectively being told in this and earlier meetings that the Department of Health were doing everything that was capable of being done in line with advice about moving from the containment to the delay phase, and in the context of pressures, including, for example, shortage of testing agents and the need to create testing infrastructure. The strategy in terms of moving from contain to delay has been set out in the action plan that we have gone to. Can you help us with some context around that?
Well, again, with the caveat around the handwritten notes previously, I think this was the executive meeting of the 2nd of March, which was the first executive meeting that I attended. And we were at that stage rapidly seeking to increase testing capacity. We would have had then a knowledge of testing capacity in other jurisdictions as recorded. Again, I'm not sure of the accuracy of those figures. And again, I've alluded to the contain to delay phase in the action plan of the 3rd of March. And again, I've gone on to say that obviously if the virus becomes more widespread and established, that we would be moving to that delay phase. And then I've alluded to the introduction of shielding at a later stage.
Just on contact tracing, you chaired the contact tracing steering group, is that correct?
That's correct, yes.
And as part of that role, did you have some oversight of the Public Health Agency and their contact tracing operational role?
Yes, both the contact tracing and the testing from their operational role in both of those areas. And
you touch upon in your statement, and indeed we have the statement from the Public Health Agency as well, Dr. Joanne McLean. Do you think that vital time was lost by the public health agency's difficulties in contact tracing capacity?
I think we paused community testing and contact tracing at the same point right across the United Kingdom. The Public Health Agency was the first public health agency to begin contact tracing again, firstly in a pilot phase on the 27th of April, and then fully on the 18th of May, which was some 10 days ahead of the resumption of contact tracing in England, for instance. And I recall that in England and Scotland, and it wasn't until the 1st of June that it was commenced in Wales. So I do believe that the Public Health Agency worked extremely hard to recommence the service that had been paused, and did so as early as was possible.
Okay. In your statement, you do say that the department did not set up specific targets in respect of delivery of the Test, Trace, Protect strategy, rather requiring the Public Health Agency to deliver and report against the overarching strategic objective. Why did Northern Ireland prefer not to set specific targets? There's an old adage that, hit the target, miss the point. And we didn't set headline targets for the sake of setting headline targets. The clear objective, strategic objective set of the testing programme and to the contact tracing programme was to scale up capacity as quickly as possible. In my view, the PHA, working with the Regional Virus Laboratory, working with the Scientific Consortium, and working with the National Testing Programme, scaled up PCR testing as quickly as possible. Similarly, I believe the PHA did scale up contact tracing as quickly as they possibly could, notwithstanding the technical challenges with that, moving from initially a telephone-based model to a hybrid-based model using digital support as well. So I'm not certain that, if I'm honest, that setting targets would have improved the commitment of all to achieve that. There were specific performance targets set by the PHA, for instance, in relation to the number of individual positive cases that were contacted within 24 hours, the number of their contacts that were contacted within 48 hours. Those were reported on a weekly basis, published in the public domain, and were shared by the Minister with the Executive. The capacity and expanding capacity on testing was again considered at every meeting of the Test, Trace, Protect Oversight Board, which I chaired, and we received a weekly report from the Northern Ireland Pathology Network about the efforts that were underway to expand Pillar 1 PCR testing. So there was no lack of scrutiny or oversight, and I think all were committed to expanding both programmes as quickly as possible. Okay, thank you. Just turning then to topic 6, inequalities. In your statement, we don't need to turn it up, but you acknowledge that the department did not engage with community groups in great depth due to the emergency situation. Do you believe that that was a mistake, not to prioritise communication with community groups?
I'm not certain that that's exactly what my statement says. I think that we've indicated that we would have wished to engage to a greater extent than was the case, and there were limitations in the middle of an emergency response to the pandemic. There was extensive engagement with community groups. I can give a couple of examples if that's of assistance. Early in the pandemic response, the Public Health Agency produced a Health Inequalities report, which demonstrated the impact that the pandemic would have, the NPIs would have, and indeed the contact tracing programme would have in terms of health inequalities, ethnic minority groups, etc. They developed a contact tracing vulnerable groups action plan to specifically target those groups, to offer differential testing. For example, they established a helpline dedicated for the Roma community in Northern Ireland. All of the information leaflets were available in many languages. There were videos, there were animations, all of which had subtitles. Another example in terms of our Northern Ireland SMART programme, which was the community-based rollout of LFDs, lateral flow devices. There was extensive engagement with third sector organisations. And indeed, the community or the contact tracing steering group, which had been established in early May to support the Public Health Agency, engaged with the Human Rights Commissioner, the Equalities Commissioner, the Children and Young People's Commissioner, the Older People's Commissioner, and indeed third sector organisations, again representing the homeless population and underserved population. So we were very clear, because we knew that unless there was equitable access to contact tracing and testing, and that was based on engagement with community leaders who were trusted in those populations, that we would not be able to provide those populations with the protection and the service that they deserved.
Thank you. Thank you very much, Professor McBride. I'm afraid we turn to, not afraid at all, but we turn, I believe, to some CP questions now.
Thank you. Mr. Thomas.
Good afternoon, Professor. My name's Leslie Thomas.
Good afternoon.
I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Workers Organisations. At paragraph 346 of your statement, you confirm that the department did not have a specific policy in relation to testing in places of worship or those living in overcrowded accommodation. As ethnic minority communities are more likely to live in multi-generational households, do you accept that the absence of culturally competent policy guidance in specific relation to this, what I've just indicated, was a missed opportunity to protect these minority groups?
I don't think that's an accurate reflection of my statement, and indeed I go on to state later in that same section where I refer to hard-to-reach populations that we did go to significant lengths, as I've just outlined to Council, to ensure that we had culturally sensitive programmes which were accessible to a range of people living in Northern Ireland, including those from ethnic minority groups. We had specific targeted testing programmes, again, where we knew that individuals predominated from those ethnic minority groups, and that included those working in the agri-food sector, those working in manufacturing, essential retail and construction. We worked very, very hard with local employers, for instance, in the meat processing plants within Northern Ireland, where we had a significant number of outbreaks, and the Public Health Agency engaged extensively with individuals working in that sector who, you're absolutely right, lived in homes of multiple occupancy, shared transport. And it was important that the advice that we were providing, the access to testing and the contact tracing was culturally sensitive and was something that those populations found acceptable. So, I mean, I was not across the detail of that, but certainly as chair of the Oversight Board, I was appraised by the PHA of the efforts that they were making in that respect.
At paragraph 362 of your statement, you say that the department's advice to the NI executive to inform reviews of the regulations took account of available disaggregated data regarding patterns of those testing positive, for example, in relation to age, gender, deprivation. It's important for FEMHO to understand whether this data was also disaggregated by way of race. Can you comment on whether the data was disaggregated in this way?
No, unfortunately it wasn't, and I think that was a gap, and I think it's an important learning point that not only do we need to be able to disaggregate the data as we did at the sort of age, gender, socioeconomic group, for instance, that we need to be able to do that by ethnicity. That was a gap that needs to be addressed. We have subsequently rolled out a new electronic care record to all trusts in Northern Ireland, which has 5 specific fields which will now ask about ethnicity, country of origin, preferred language, etc. So hopefully that will be addressed in the future.
Well, I'm glad to hear that gap's been plugged. I suppose the only follow-up question I would have is, do you have an explanation as to why there was that gap? Was that just an oversight?
No, well, basically ethnicity is poorly recorded. It was poorly recorded in healthcare systems in Northern Ireland. We weren't recording, for instance, ethnicity on testing forms. We did and had some attempted, we did attempt to disaggregate that data by a country of birth. However, again, the ability for us to do any qualitative assessment on that was actually limited by the fewer numbers of people from ethnic minority groups living in Northern Ireland compared to other parts of the UK. That doesn't make it acceptable, but I do think that we have the means now to address that.
Okay. At paragraph 694 of your statement, you say that it was not possible to analyse trends relating to ethnicity in Northern Ireland due to poor coding of ethnicity in healthcare records, as routine data flows did not allow for the identification of trends in the transmission and infection rates of COVID in different ethnic backgrounds. Just a couple of questions. Can you explain how this lack of data impacted policy decisions, and what strategic or policy outcomes could have potentially been achieved that were undermined by this lack of data?
I think certainly it would have been absolutely preferable had we the ability to have carried out that analysis at the time. We didn't. We now do have. But again, it still is based on the voluntary disclosure of that information by the individual themselves, and indeed the coding of that by the health professional. Whilst we didn't have access to that data specific to Northern Ireland, we did have access to the data that was being generated in other parts of the United Kingdom. So, for instance, my Deputy Chief Medical Officer, Dr. Naresh Chadha, was a member of the working group chaired by Professor Fenton, looking at the disproportionate impact of the COVID pandemic on individuals from ethnic minority groups. And we were fully aware of that data, and that did inform policy decisions in Northern Ireland. We had no reason to think that the data and the research findings would be different in Northern Ireland, but again, I agree it would have been preferable to have local data.
Okay, final question, and it's this. In hindsight, do you believe that empowering local ethnic minority-led organisations could have improved testing uptake and compliance with isolation measures in their communities? And what steps could be taken to implement such measures going forward in the future?
I completely and wholeheartedly concur. It is important that when, whether it's any public health messaging is about affecting behavioural change, it isn't about telling people what to do. And it is about working with local communities and trusted leaders in those local communities to communicate message in a way that is actually culturally sensitive and is understood by that population. So I entirely accept the point.
Thank you, Professor. Thank you, Milady.
Thank you, Mr. Thomas. Mr. Wilcock.
Good afternoon, Professor. I represent, as you know, Northern Ireland COVID-bereaved Families for Justice. In fact, 90% of the questions I wanted to ask you have been covered by other people, so I'm not going to repeat them. Okay. I'm going to ask you about a different topic in terms of this module, but an all too familiar topic in relation to previous modules, which is the heavy workload that was placed on you by the system in responding to COVID. In your statement, you mention a number of boards in relation to testing issues, which you set up, including the Expert Advisory Group on Testing, the TTIP board that you referred to earlier on in your evidence this afternoon, and the SMART board established on asymptomatic testing in March 2021. Now, the then Minister of Health, Robin Swan, has made a statement to the inquiry that while he greatly benefited from you having a policy role in addition to his advisory role during the pandemic, it also served to highlight the heavy workload of and reliance on the CMA role in the pandemic response. First question is this: was the heavy workload that was being referred to by Mr. Swan and that we've heard about one of the reasons you set up the several boards I've mentioned and the others that you've listed in your statement?
I'm not sure that follows, if I'm really honest. I think that the establishment of those various working groups was essentially to ensure that we were making best use of the finite expertise that there was from a professional and scientific basis in Northern Ireland. And as I said earlier, my lady, we worked in a very integrated way with local science, with academic partners, with the Public Health Agency. The truth of the matter is Northern Ireland was just too small to maintain discrete organisational boundaries where it was much more efficient and effective to work in a much more joined up and integrated way, and that's what we did. So if I take, for example, the various boards in relation to testing and contact tracing, my own view that those were a very efficient way of working together to provide support to the Public Health Agency, which in relative terms is a small organisation, but also ensured alignment between operational delivery and policy. So it reduced fragmentation, it ensured greater efficiency and effectiveness and worked well. I think I would accept the point, and it was made in expert witnesses to Module 2C, that too much was asked of the department. By any comparison, it's one of the smallest departments in the Northern Ireland.
Talking specifically about the CMO at the minute.
I'm going to come on to that. It's one of the smallest departments in Northern Ireland, despite having the biggest budget. And at that time, in my view, looking back on it, the Chief Medical Officer role had both significant professional advisory responsibilities and also significant policy responsibilities. That has now changed. In that the significant areas of the policy responsibility no longer sit with me, although I provide separate advice to policy colleagues who lead on that. And I think that should a similar situation arise again, I think that's a much more effective division of responsibility.
So if I could just test that answer by asking you about the change that you've just referred to, because what Mr. Swan says in his statement is that the Department of Health has since, and I quote, reacted to the heavy workload and reliance on the CMO by making sure the CMO no longer has a policy remit. You've told us about that. When did that change take place?
The change began in and around, I think, April 22, and has evolved since that time. So it's probably towards the latter end of the pandemic response. I may not be correct in that.
I don't think anyone's going to quibble about a month.
But it was certainly in the latter part of 22, early 23, probably early 23, if I'm honest. Actually, maybe in April 23.
I think the more important question I need to ask you is, did you support the proposal that your policy role be curtailed?
Fully. I mean, these are individuals who I've worked with for the past 16 odd years. I still have close liaison with them, and we work effectively as one team. So I think the fact that I don't have budgetary responsibility, I don't deal with the HR issues, I think actually frees me up to concentrate and focus on the professional and technical aspects, and to ensure I can provide more professional advice across more policy areas.
And does it follow from that no matter how hard you undoubtedly tried to cover the heavy workload placed on you, too much was being asked of the CMO during the pandemic? Well,
I was supported throughout by a very able team. I had 2 deputy chief medical officers. I had a chief scientific advisor, extremely experienced team, and I had a small number of senior medical officers. And as I say, we worked in a very integrated way with the Public Health Agency, and also I benefited from tremendous support from academic colleagues working in both of our universities, in Queen's University, Belfast, and in the University of Ulster. So, it wasn't just me. There was a team of able people supporting the roles and responsibilities that I had at that time.
But equally, that team of able people were still in existence when the role was curtailed in late 22, early 23, whenever it was.
Yes, but I think the point I would make is that we all had to step up at a time of unprecedented challenge. The job that I had was the job that I applied for and was appointed to. And whenever the department activated its emergency response plan, which it did on the 27th of January, the responsibility for the coordination of the health service response and the public health response, as defined in that plan, fell to me and my team. We did that, and we were supported by other colleagues across other policy areas within the department, and we were supported by other government departments in terms of loaning us additional people to assist with the responsibilities that the department was carrying at that time.
Professor, thank you very much for those.
Thank you.
Thank you.
Thank you, Mr Wilcock. That completes the questions we have for you, Professor McBride. I can't guarantee. I think we are calling you again. I think so. I'm definitely
you
not.
are in July, my lady.
What I'll try to do is ensure that we don't call you again thereafter.
Can I hold you to that?
We have to. But thank you very much for the help you've given. There may be those who criticise the overall response, but I don't think anyone could criticise you and your colleagues for the amount of dedication you showed during the pandemic to trying to save the lives and the health of the people of Northern Ireland. So thank you for all your efforts, and thank you for your help with the inquiry so far.
Thank you, my lady.
Right, I think we're ready for Mr Swan. Sorry you've been waiting so long, Mr Swan. I'm afraid you're the last witness. Is it right if Mr Swan is affirmed or takes the oath?
If you don't mind me moving whilst he's being sworn.
Okay,
just be
we'll
one.
wait.
Sorry, I just.
As everyone knows, I don't like.
No, of course, I appreciate that, my lady. Thank you, my lady. Please, can Mr Swan be sworn?
Thank you.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Could you please give your full name to the inquiry?
Robert Samuel Swan.
Thank you. Mr Swan, you provided evidence to the inquiry before, but in respect of your Module 7 statement, could we please move to page 101 of that statement? It's a statement dated the 8th of April of 2025, and can I ask you to confirm that the contents of that statement are true to the best of your knowledge and belief?
I can, yes.
Thank you. Now, in respect of you and your background, can we just confirm that which you've spoken about in other modules? It's right, isn't it, that at the time of the pandemic, you were the Health Minister from the 11th of January 2020 to the 27th of October 2022, and again on the 3rd of February 2024 to the 28th of May of 2024.
That's correct.
Thank you. And is it right more broadly that you are the Ulster Unionist Party MP for South Antrim and have been an MP continually since the 4th of July? Can you just confirm the date?
2024.
Thank you very much indeed. Now, obviously, the focus of your evidence today is going to be on your role as the Minister of Health during the pandemic, and particularly it's going to be helpful to look at the decision-making in the March time. But before doing that, and I think to contextualise some of the decision-making and the issue of cross-cutting issues, you helpfully detail within your witness statement the ministerial code and the relevant paragraphs. I think it's 2.4 of the ministerial code. But perhaps so it's absolutely clear from your perspective as the relevant minister, and let's confirm this first of all, you accept and tell us throughout the statement that you were essentially responsible for the policy and strategy and decisions relating to TTI.
That's correct, yes.
Excuse me. And so can I ask you to explain from your perspective the issue of cross-cutting, but also matters relating to TTI that needed to be taken to the executive?
I think, my lady, in regards to this, when people talk of cross-cutting issues within the Northern Ireland Executive in that sphere, there's two very different perspectives in regards to that. There's that which comes under the Ministerial Code, which is cross-cutting and controversial, and has to be deemed so and can be deemed so by the First and Deputy First Minister acting jointly, where a decision or a step taken by a minister can actually be called in and challenged by the executive, or those issues that could be more colloquially known as cross-cutting, is where actually ministers can work together and work in partnership without it having to be a large executive issue or a problem, or even that is controversial, that actually shows, I think, the good working relationships that we see across politics. And in part in regards to TTI, especially in Northern Ireland, I think I had that cross-cutting partnership approach, especially in the early stages with the Minister of Communities, in regards to how they were able to set up, the discretionary support payments, so that people that we were asking to isolate actually had those supports. There were also those cross-cutting when it comes into the testing, whereas later on we were able to work with the Minister of Agriculture in the utilisation of the AFBI labs, so we were actually increasing testing capacity as well. So in regards of what can be deemed cross-cutting, it's not always controversial in Northern Ireland, and I think in stages of this part we actually saw a good partnership working in that.
Thank you. Well, perhaps if we can display, please, it's page 8 of your statement, and it's paragraph 13, because in giving that answer you've obviously identified the different departments where you had to liaise, and I just want to be clear from your perspective. So we can see there's the paragraph 2.4 of the Ministerial Code, which requires ministers to bring matters to the Northern Ireland Executive, and obviously one of those features being a matter which cuts across the responsibilities of 2 or more ministers, and I think you've identified different departments and ministers there. I suspect we could probably spend a week talking about cross-cutting issues and the litigation that's arisen out of it in particular. But what we really want assistance with, if it's a straightforward answer, but if it's more complex, please tell us. In respect of the issues of test, trace and isolate that we know you had the responsibility for, was there a requirement under the code for those to be taken to the executive?
Not specifically under the code, but under the cross-working of the executive in regards to how we were actually working as a newly formed executive, formed on the 11th of January of that year, a few weeks later being forced into in regards to this. There were those issues that needed to be discussed, needed to be understood, I believe, by all executive ministers, and that's why we brought those, our test, trace and protect, our testing strategies always to the executive to make sure that they were informed of what we were doing under a policy decision, but also why we were taking those decisions, but also to give them the opportunity to input and also challenge if they saw fit.
Thank you. Now, we've identified the strategic policy decision role you have for TTI, but it's right, isn't it, that the PHA, the Public Health Agency of Northern Ireland, was essentially the operational arm to implement testing and contact tracing?
They were the delivery body for that. They were our public agency in regards to that was their standard role, that was their responsibility, and that's where the professional delivery mechanism actually lay. They were an arm's length body with their own board, their own chief executive, accountable to themselves.
Thank you. Now, quite separately, we know that Public Health England existed in England, but can you just confirm that throughout the pandemic, that Public Health Agency in Northern Ireland remained, it was a constant agency in Northern Ireland?
It was throughout the pandemic because of their expertise and what they did in regards to that public health messaging, in regards to the contact tracing side, and with experience of testing for other diseases and other issues that they had to deal with. They had that expertise. There was a step taken during the pandemic when Public Health England was stepped down with its functions devolved across different parts of the Department of Health and Social Care in England. I didn't think that was the right thing to do, again, because of the expertise within the organisation, but also the size of the scope that we had in Northern Ireland, even the additional capacity that was within the Department of Health where those responsibilities could possibly have been transferred to. So to me, it made sense to retain PHA in its existent form and in its entirety.
Thank you. I think perhaps can you slow down slightly so the stenographer can keep up with both of us, please?
Apologies.
Now, we've already identified that you were the Health Minister from the 11th of January 2020, and you've just contextualised that essentially this was when the executive started and the government in Northern Ireland commenced its work again, at the same time as a pandemic is coming towards all of us, and in particularly Northern Ireland, for the context of your evidence. Can you give some context then to her ladyship? Obviously, you're a new health minister in a newly formed government again. As to any relevant context when we're looking back and analysing the decision-making and the infrastructure at that time in Northern Ireland, please.
I think, my lady, to really put that into context, we as a party didn't decide until the Saturday morning that we were actually come back into the executive. So it was a decision that was made by my party's executive. At that morning we went in, and then as ministerial positions are given out by the hunt rather than pick, we had the penultimate pick, and at that stage agriculture and health was left, and my then party leader selected health and asked me to take up the role in regards to that for what was meant to be a short period of time while things got settled, because I'd actually stood back a few months previous as the party leader in regards to that, but it developed then in regards to having to get into the role very quickly. What actually came about, the challenges were faced. Party leader Steve Egan at the time asked me to stay on in the role. I did throughout the pandemic, and then subsequently went back in the second time as well, because I saw the value of the point, I saw the value of the post, and I thought there was actually merit in our party taking it in regards to the fact that we were a single ministerial position within a multi-party executive. So whereas in other instances throughout periods of challenge in Northern Ireland where party lines can fall and separate between the two larger parties, as us being a single party minister within that, I thought, and I hoped I did, and I believe I did, was able to work across those party boundaries, because we weren't coming with any other agenda apart from that public health agenda in regards to how we were operating and working within the Northern Ireland Executive.
Thank you. Can I ask you, prior to January 2020, had you ever had a ministerial portfolio?
I hadn't, no. I chaired the Public Accounts Committee and the Employment and Learning Committee, but not a ministerial role.
Thank you. And then can I ask you, in terms of relevant expertise, particularly where it's health, do you have any particular skills and expertise from experience before that time that helped inform health matters?
I think, my lady, and it's a personal reflection, and I do, and I used it during my time as minister. He does know I use this example. Our son was identified pre-birth with a congenital heart defect, a single kidney, and atresia of the bowels. So when he was actually born, he spent the first 13 months of his life in the Children's Hospital in Belfast. So from an operational point of view, from a personal point of view, we got a very hands-on, very family approach in regards to actually what our health service meant, what it can deliver. But it also showed me as well when it came to the 2 open heart surgeries that he had, but also he had a pacemaker in place before he was one that was done in Birmingham. So it showed me that partnership working, looking across, looking outside Northern Ireland was a benefit we can actually do, we can work from. His health since had that pacemaker replaced, a 10-year-old malady in Dublin, because of the all-island paediatric cardiac corroboration we have. So I experienced from a personal point of view what our health service in Northern Ireland is, but was able to come to the role with an understanding that for us to do what we needed to do, there was help out there when we needed it. And I think that actually helped shape how I was able to approach not just the internal relationships that I spoke earlier in regards to the internal workings of the Northern Executive, but also on that cross-departmental, cross-jurisdictional boundaries as well.
Thank you.
Sorry you had to get experience in that way, Mr. Swan.
My lady, I was sorry as well, but I can assure you our son is now in his first year in secondary school, and comes with his own challenges now as a teen.
Can imagine.
Mr. Swan, obviously completely appreciating the very personal and lived experience of the healthcare system. Can I then look at it from a different perspective as to infrastructure, but also the particular skills and knowledge that were needed in a pandemic? Can I seek to capture with you the infrastructure that existed pre the decision in March of 2020? To do that, can we use your witness statement, please? It's paragraph 34, please, page 15. Now, thank you. So I'm going to work through the infrastructure that existed. Now, one of the things when we come to look at the minutes of the ministerial meeting of the 16th of March, we see their reference to the fact that you say, essentially, I've been preparing for the past 7 weeks. And so if we give a rough and ready to that, it looks like around the end of January then, that you are referencing that you had started making preparations. And so can we then work through together whether you'd appreciated by the 16th of March, or before then, the 12th of March, the laboratory capacity that existed in Northern Ireland?
Well, I think I'm preparing for this statement, and again it goes back to Northern Ireland politics. There was a review of pathology services and labs in Northern Ireland actually completed, in my understanding, 2016. It went out to public consultation in 2017, and then the executive fell, so there was no minister in place. So when I came into post in 2020, there was a pathology review that was put forward in regards to what we needed to do to expand and enhance our laboratory capabilities in Northern Ireland. At that point, not specifically in regards to testing for COVID-19. So I took that forward at that time. Two of the steps within it was actually that electronic update in regards to a single electronic system working across all their labs that were reporting into one central location, but also re-establishing, whereas our labs are working in the 5 different geographical trusts. Our virology lab sits under the Belfast Trust, actually bringing them into one network as well. So that work commenced early 2020. The challenge that I think is unfortunate in regards to Northern Ireland, following the public consultation in 2017, ministers could have made those decisions to start to actually build our lab capacity in regards to that. In specific, in regards to the comment in regards to we've been preparing in different ways. In regards to how we were going to prepare health, working with our GPs, community pharmacies and hospital provision as well, so different across the health service family. In regards to the laboratory provision as well, until we actually knew the pathogen we were working with, and I think the genome, I don't think we had that available until early February.
Thank you. And so what I'm wanting to explore with you, because obviously you as a health minister have a very unique perspective of what was needed and what had to happen. And a number of individuals and evidence we've got from other health ministers is essentially there was no playbook for what was happening. And so what I want to understand is, we get to January, you start to talk about preparations. How quickly did you identify the laboratory capacity that was going to be needed to respond to the coronavirus pathogen?
Well, in regards to, I suppose, that point, January to March, it was that period in regards to we weren't really aware of what was coming in the large scale in regards to that. We weren't, and again, it's about able to scale up a laboratory facility for a known pathogen and an unknown pathogen in regards to what assays were going to be used, all the rest of it. So it's how we actually started to talk, and again, I think the CMO referenced, it was how we worked across academia, how we were working with our different departments in regards to what lab capabilities were going to be or what we could actually access.
Okay, Can I ask you about that in the context of the evidence we have about the Public Health England assay, and see if you can assist when essentially the assay was available in Northern Ireland? So the Public Health England assay was used at the Public Health England Colindale laboratory to diagnose the first case in England on the 31st of January 2020. Thereafter, the information suggests that PHE isolated and grew the SARS-CoV-2 virus from that first UK diagnosed case, which provided the essential control material for the use of the assay, which on the 10th of February 2020 was rolled out to 12 Public Health England labs across the United Kingdom. Do you know that as part of that rollout of the assay, would that have then also been provided to the laboratories in Northern Ireland as of around about the 10th of February 2020?
My understanding was that the Royal Virology Lab within the Belfast Trust received that assay on the 10th of February.
Thank you.
It was allowed to do that work as well.
Thank you. And can we then look at the different laboratories and noting then that the assay existed in Northern Ireland from the 10th of February? You tell us in your paragraph 34, please, by way of the infrastructure, that the Regional Virology Lab and Regional Services for Genetic Testing is based in Belfast. And you tell us that in January 2010, the baseline PCR capacity across all of the HSC laboratories. And can we just confirm how many HSC laboratories there were, please?
My understanding is 10 across the 5 trusts.
Thank you. And obviously you've given us an indication that there were 40 tests per day capacity. If we go over the page, please, just to look at the capacity at paragraph 35. So we've got 10 of the HSC Trust laboratories. How many of the virology laboratories were there?
I don't know off the top of my head an answer in regards to that, but in regards to in 35, when we're actually looking at the additional scale up in regards to that, it was actually about that academic consortium that we established, utilising, as we say there, Queen's University Belfast, the Ulster University, Agri-Food and Bioscience Institute, Milady's the Veterinary Service Laboratory, so that's under the Department of Agriculture, so we're also actually working with them. They were part of that academic consortium, as was representatives from Almac, who were a private provider as well. So it was actually utilising all that laboratory capacity we had in Northern Ireland in a partnership approach rather than solely going for a single contractor and buying that in.
Now, I think you tell us a little later in your statement at paragraph 40, we don't need to move to at the moment, that it was March when the academic consortium was created. Is that correct?
That's correct, yes.
And so was it then, can you help us, when in March that the identification of other laboratories to be utilised and essentially the pivoting of the use, particularly of the university laboratories and the agricultural and I think the veterinary laboratory capacity was essentially adapted to be able to make the PCR tests?
Yeah, again, I think it went to the other health trust labs around the 27th of March and the AFBI lab around the middle to the end of May in regards to that, and then Almac as the private partnership, the private partner we had in that too was around August 20 as well, because again, it's not just a matter of the lab, it was also the virus itself that we were working with to make sure that all the protocols, all the safety protocols were in place for those labs actually to handle those samples as well.
Thank you. And then in terms of Almac, does that stand for anything or is it just the name?
It's the name of it's a laboratory provider in Northern Ireland. It's a private company.
Thank you. Now we know that Randox Laboratory was being utilised, particularly also by the mainland. Did Northern Ireland utilise the Randox Laboratory that was based within Northern Ireland?
As part of the national testing protocol, so the contract with Randox was with DHSC, and we had our Barnett consequential or Barnett share of those tests as well. So the overall contract was with Randox. We classified that as our Pillar 2 testing programme, whereas we were still operating the Pillar 1 testing programme, which is our own labs, and as I say, AFBI and the Almac labs as well.
Thank you. My lady, I think that's probably a convenient
Certainly.
place to take the break. Thank you.
I shall return at 3:15.
Thank you, my lady.
Ms. Cartwright.
Thank you. Mr. Swan, can we continue, please, with the theme of infrastructure and scaling up from the February to the March, please? So in respect of testing, once the assay was in the laboratories in Northern Ireland, are you able to help us as to any oversight you had for the scaling up of testing in that first month from around about the 10th of February to the 10th of March, please?
Well, again, in regards to oversight that I had, that was actually under the academic consortium that we had established under the chairmanship of the Chief Medical Officer in regards to how, again, those laboratory protocols, the practicalities and also the safety measures. But also one of the limiting factors, not just in regards to the assays, was...
Sorry to interrupt you, Mr. Swan. We really are going to have to slow down to help the stenographer, please. I'm sorry to interrupt.
No, you're okay. So it was about the capability, also the supply of reagents, of swabs. You know, a lot of the platforms that the assay was being developed on, if I recall right, it was actually a roach-based assay as well. So I know it was a problem actually getting the reagents and some of the protocols that we needed for that.
Thank you. And I just want to just check on that answer, because the academic consortium, I don't think, was created until the March.
Yes.
And so for the February period of time, is there anything you can assist before the academic consortium was convened that you can help us with as to what was practically being done to scale up testing?
Well, again, it was to work through the RVL, the Regional Virology Lab, and who had the expertise in regards to how they actually maintained and worked with what were extremely contagious pathogens at that stage.
Thank you. And again, we know that the handling of the pathogen, again, within this period, was changed from containment level 3 to containment level 2. Do you have any of the detail as to how many containment level 3 laboratories existed in Northern Ireland?
That's not something I would have the detail of.
Thank you. Can I then move on to assistance as to the infrastructure around contact tracing, please? Can you help us then as to what existed in January through to March? We can certainly see that there was scaling up of contact tracing that came on in April thereafter. But what existed in Northern Ireland, please?
Well, at that stage, the PHA's contact tracing was a relatively small unit based on Lennon Hall Street in Belfast, and it was contact tracing for things like whooping cough, tuberculosis, so very small numbers, very specific groups in regards to how they were working and testing. The scalability capacity of that, even within that facility, was quite limited. So that's why at a later stage we actually moved to the County Hall, larger facility, just outside Ballymena, which was able to actually accommodate physically the infrastructure that we needed for that larger scale testing cohort of personnel.
Thank you. And again, just coming back to the 7-week preparations that we see in the executive meeting that we'll look at and the minutes on for the 16th of March. Anything else that we've not dealt with that identifies what you were headlining as 7 weeks of preparatory work?
Well, I think in regards to that, Milady, and I think it was covered in 2C, they've been referred to as minutes. Those are handwritten notes that I had in sight of prior to preparing for the inquiry as well. So there weren't actually something that was either validated for the content or taken in context in regards to how that facilitated or where it actually sat in terms of a conversation or a debate that was going on within the executive. But it was about that general preparation that the Department of Health was doing in preparing for COVID.
Thank you. Well, we'll bear that context in mind when I do use those notes to ask you for your assistance about the discussion. Can we then please move on to the issue of the decision around the 12th of March at that COBRA meeting, what that meant from the moving from the contain to delay? And can we please then highlight your paragraph 21, please? It starts on page 10. Sorry, the paragraph starts on page 10, but I want us to move to the paragraph on page 11. So perhaps if we can orientate first of all, please. Thank you. And if we can move on to the next page, please. Thank you. You tell us in paragraph 21, on the 12th of March 2020, contact tracing was paused in line with the decision which was taken by the Cabinet Office briefing room ministerial meeting. Contact tracing in Northern Ireland remained paused until it was reintroduced by the Public Health Agency on the 27th of April 2020, initially through a pilot phase, and then with a full launch on the 18th of May 2020. And you tell us that in the intervening period, from the 12th of March 2020, contact tracing continued in health and social care settings, including care homes. Is that correct?
That's correct, yeah.
And so is that the contact tracing through the existing infrastructure you've told us about?
Of PHA, yes.
Thank you. And can we then please move again on the same topic just to contextualise the 12th of March, what you say in your witness statement, please? It's paragraph 155, please, which is at page 51. So paragraph 155, please, at page 51. Thank you. And so this is the rest of the context for the 12th of March. You say this: on the 12th of March, contact tracing was paused in line with the decision which was taken by the Cabinet Office briefing room ministerial meeting. I believe the decision was in line with the UK-wide agreed protocol for moving from contain to delay, and with the UK-wide Coronavirus Action Plan dated the 3rd of March 2020, which was agreed by the 4 United Kingdom governments with advice from the UK CMOs and government scientists. I referenced this in my statement to the Northern Ireland Assembly on the 9th of March 2020. I do not now recall any specific discussion or advice that Northern Ireland should adopt a different approach, but there were operational pressures on contact tracing services and limited testing capacity at this time, which made it difficult for both to continue in the community. The Northern Ireland First Minister and Deputy First Minister also attended the COBRA meeting along with officials from the Executive Office, and I do not recall that at any point it was queried whether Northern Ireland should continue contact tracing. As the First and Deputy First Minister were also at the meeting, I did not consider there was a need to refer the matter to the Northern Ireland Executive. As they made no such referral either, I can only assume they also thought it was not necessary. And so, would you indicate or accept that that is your position around this difference of opinion that appears to exist between yourself, the First Minister at the time, Baroness Foster, and Miss O'Neill, who we've heard from today?
I would agree. That was my perception of, I suppose, the sequence of events from the 3rd of March conversations in regards to that. And I think it was the first COBRA meeting that the First and Deputy First Minister had attended in that role. It was the first one that was chaired by the Prime Minister in regards to that. So that decision, that sequence of events is as I recall it, and that's my perception of it. As I referred earlier in regards to those issues that can be cross-cutting or controversial, the First and Deputy First Minister have the power to call any decision or any decision that's made by a minister actually into the executive for a different approach to be taken, and that's why I made that. As they made no referral at that stage, it was my perception that they understood the process of events, the sequence of events, and the decisions that had been made.
Mr. Swan, Professor McBride was generous to the former First Minister and Deputy First Minister, now First Minister, suggesting they may not have understood the decision at COBRA. Did you think there was any doubt about the decision having been taken at COBRA to pause contact tracing?
I didn't, my lady, but in regards to reflecting on what I've heard this morning, but also reading, I do think there maybe is that not a misunderstanding, but not understanding what was agreed or what actually those points in executive papers and especially the COBRA minutes actually mean in regards to that. But I think in the COBRA minutes, Professor Chris Whitty is very clear that it is about the stopping of testing and contact tracing in all geographical areas. So to me that was pretty clear in what it meant. Now, I can't, I suppose, make assumptions the other two. In regards to the questioning and querying, both from the First Minister, Deputy First Ministers and other ministers, they weren't behind the bush in coming forward in regards to asking queries or clarifications, or indeed submitting to my department what was an FIR, which is a further information request. So we were used to receiving those additional queries in regards to what does this mean, what is the capacity. I don't recall any on that specific issue on that time frame, but it was quite a hectic time frame.
Mr. Swan, can I ask you then, from the perspective of health being a devolved matter, and you being the Health Minister, with knowledge of the unique position of Northern Ireland and the communities, and essentially how people live across the 5 counties, and beyond the city of Belfast, the very unique aspect of the communities that exist in Northern Ireland. What I want to ask you is, you say I do not now recall any specific discussion or advice that a different approach should be adopted. And what I want to ask you as a relevant minister, living in those communities, knowing Northern Ireland, but also that Northern Ireland did not have that many cases at that time, why you didn't consider a different approach, whether in fact Northern Ireland should be saying, actually, it's not right for us at this stage where we're at to stop testing or to stop contact tracing.
And I think, my lady, in regards to the 6 counties of Northern Ireland, yes, in regards to that,
insulted the whole of Northern Ireland, so apologies.
No, you're fine. In regards to that, and I think it was about the testing capacity that we had at that point. I think there's a statement there's about 100 plus 120 tests we had per day, and it was actually how we utilised those in regards to that. So it moved from contain to delay. We were asking people with symptoms to self-isolate in regards to that. So the need of using a test to verify what was already guidance in regards to that, where we were actually then, we used that testing capacity within those healthcare facilities that were mentioned in the earlier paragraph as well. So it wasn't that the testing stopped. We were testing what we thought was that highly, I suppose, critical, highly need in regards to using tests within hospital settings, care home settings as well, but also using that tracing capacity then to follow up in those cases too.
And so then can I be clear, Mr Swan, that at any point did you give consideration that you should have been saying that a different approach was needed in Northern Ireland?
Not in that specific point, no.
No, not at that point, but at any point, Mr Swan?
In regards to this incident, no, not at that point, no, not in this instance.
So did there come a time when you thought a different approach was needed for Northern Ireland?
Well, there were different aspects where we did use different approaches in Northern Ireland, but in regards to this one, no.
Okay. Can we then, please, before looking at the minutes, look at the action plan, which has been referenced in the evidence today of the 3rd of March of 2020, please, which is INQ 232520. That's INQ 232520. I want to go to page 3 where we see the action plan having essentially the badges of the 4 nations. Now, obviously, this is the document that seeks to detail what it means to move from contain to delay. And can we perhaps just look at some of the pages? Because although it was plainly highlighted by Professor McBride, there is one paragraph that references moving from contain to delay would suggest a change to contact tracing. But when you go through the whole of the action plan, what was your understanding about what a move from contain to delay meant? And perhaps if we go to the delay phase and go into page 16, it's internal page 14, but page 16. Thank you. And so this is where it says the delay phase, paragraph 4.2.3. Many of the actions involved in the contain phase also act to help delay the onset of an epidemic if it becomes inevitable. These include case finding and isolation of early cases. And so with that being said out there, that sounds like contact tracing to me within a delay phase.
Well, if there had been, I suppose, my lady, the availability of testing at that capacity, and I think it's important to put into context regards. When I talk to people now about the COVID pandemic and testing, everybody automatically recalls the LFDs that people were able to order to their homes in regards to these utilisation and the availability of those, rather than going back to March 2020 where we were talking about a limited number of PCR tests as well. Just by my understanding of that in regards to these include case finding, which was the identification of case, but also to separate out the isolation of early cases. So at that stage we were advising anybody with symptoms to isolate, and then further after that anybody who would come in contact with someone who had symptoms as well. So my reading of that in context and at this point is that it's not necessarily contact tracing that sentence specifically refers to.
All right, and let's then move forward, please, to internal page 17, but it's page 19 of the INQ, please, which is the phased response with what we will do next. And we can see in the event of the outbreak worsening or a severe prolonged pandemic, the response will escalate and the focus will move from contain to delay through to mitigate. During this phase, the pressures on services and wider society may start to become significant and clearly noticeable. The decision to step up the response from the contain to delay and then mitigate will be taken on advice from the UK's chief medical officers, taking into account the degree of sustained transmission and evident failure of measures in other countries to reduce spread. And so again, would you agree that this looks like it required a very bespoke view of the position in Northern Ireland, not following what the UK was doing where the pandemic was more advanced, but for a bespoke consideration of whether, in fact, Northern Ireland needed to move from contain to delay?
I think, my lady, in regards to that, the ability of what testing capacity we had, there was an assumption of that, Northern Ireland, yes, was behind the curve in regards to the number of cases, in regards to England and Wales, but specifically in regards to London. But I think also one of the findings, I think, that has come from earlier modules in regards to this, the fact that we closed down earlier in regards to that was actually a benefit in regards to the response to Northern Ireland. So although it was done at a time and a date that reflected across the United Kingdom, we were actually in a different sequence or a different part of the pandemic wave at that time in regards to when we actually took that decision.
Thank you. Now, if we move along, please, to internal page 19, page 21. Again, we've got the mitigate phase and next steps in the event that transmission of the virus becomes established in the United Kingdom population. The nature and scale of the response will change. I'm not going to go through all the bullet points, but it is right to look at the bullet point over the page, which is the one that Professor McBride referenced. We can see that included in those mitigation next steps was there will be less emphasis on large-scale preventative measures such as intensive contact tracing. As the disease becomes established, these measures may lose their effectiveness and resources would be effectively used elsewhere. And so would you agree that in this document it is not saying if you move from contain to delay, contact tracing stops altogether?
Yeah, but this moves on to the mitigate phase, which is the next step as well. And in March we were moving from contain to delay in regards to that. So in regard to that pause of contact tracing between March to they re-established the pilot, and I think it was towards the end of April, and then full re-establishment in May in regards to where we were in regards to capacity. So that was being built up over those stages as well.
Thank you. And so, please, Mr. Swan, using this document and what it seems to be calling upon is a nation consideration of the factors and where the pandemic was up to. Did you at any point before the 12th of March sit down with the relevant Chief Medical Officer within Northern Ireland and perform the analysis of, is it correct for us to follow the UK approach, or whether we should be saying, actually, we're going to take a different approach whilst we have less cases in Northern Ireland and have an ability to stop the spread through continuing to test with the limited capacity we have and to contact trace those cases?
But I think at that point the virus was already established within the community, and I think that has been referenced by the Chief Medical Officer and his evidence as well. So again, we were bringing about those measures at an earlier part of the curve or the wave, as they spoke about in regards to that. Up until that point, the discussions that we'd been having, I suppose, as a Four Nations approach, was that COBRA was again chaired by Matt Hancock, and it was that lead from a health point of view, from the four CMOs point of view in regards to that, and it was about us taking a consistent approach across the United Kingdom in regards to how we reacted at different steps.
Okay, so there seem the multiple features that you're referencing there, and what I really want to then consider is you've given the answer about whether in fact there was a pause moment and do almost a bespoke risk assessment for Northern Ireland, but particularly when we come to look at the 16th of March, where very clear views are being expressed by the First Minister, Baroness Foster, and Miss O'Neill, who is effectively saying, I think we're on a wrong path, the wrong trajectory. We should be testing. We should be contact tracing. When the executive and the two senior officials, the First Minister and the Deputy First Minister, were saying, we think we're making a mistake, at that stage, was there ever a reflection and a review of the risk assessment and the plan for Northern Ireland?
I don't think at that stage we'd already moved from contain to delay. So my reading, my understanding of that conversation and their statements is that none of them thought we had taken that step too early in regards to that. In regards to the comments, test, I think was an easy soundbite because it didn't match actually our capacity in regards to the tests that we had. It was the World Health Organization's approach at that stage in regards to using those abilities, but there was very few countries across I think the developed world who had the capacity to test and do those large-scale population tests at the start of March 2020.
Thank you. Well, I don't think in terms of your position I need to take you to the COBRA minutes of the 12th of March, but can I then take you to the, in fact, let's do that in fact, because Baroness Foster did raise an issue. Can we briefly then please display 56221? That's 56221, thank you. We go to page 2, we can see that you dialed in along with Baroness Foster, Ms O'Neill, and then if we, and also Dr McBride. If we then move, please, to the minutes, please, at page 7, paragraph 12, we can see that it records the CMO said once the policy of 7 days self-isolation was in place, the plan would be to stop all testing of people entering into self-isolation and to stop all contact tracing from other geographical areas. And again, the footnote is to the action plan we've looked at together of the 3rd of March. It was recommended the following symptoms be used in public communications: a high temperature and persistent new cough. A new persistent cough in the symptoms reflected that some people always have a cough at this time of year. If it was needed to help communicate this to the public, a date could be set, but that would be an arbitrary decision. Now, certainly the evidence that we've heard from Baroness Foster and Miss O'Neill is that it was not clear to them, having been on the call on the 12th of March, that the effect of the decision was stopping testing and contact tracing. Can I be clear on your view about what you took from that 12th of March meeting, please?
That my understanding was, because I think it goes back to the comments from Chris Whitty in regards that it would actually involve the stopping of testing and contact tracing.
Can we then move to the, I do apologise, the minutes of the 16th of March, please? 65689. 659. Thank you. Now, again, you've already caveated, these are not verbatim notes, it's not a transcript.
My lady, and I would like to note as well, these are not the minutes of the executive meeting. They're a very different document in regards to this, in regards to that. So,
please, can you give the clarity about this document and what it is, please?
It's a hand-transcribed note of a note taker who, up until this inquiry started, I didn't know existed. They are, I suppose, snapshots of what was said at different points in a conversation. I think this document itself moved to somewhat of 42 pages around that in regards to handwritten notes in regards to what was a very tense and fraught meeting in regards to a number of issues that had actually presented itself to the executive at that point.
Thank you. And then do you want to then give the overview? You describe it as you've just done as a tense and fraught meeting over a number of issues. Again, to give the context as I go necessarily to selective entries, do you want to give that overview as your recollection of that meeting and the various issues that were being considered, please?
I think prior to that meeting in itself, the executive had quite a solid, unified position in regards to that. My lady, in regards to one of the core issues was when we would close or not close schools. Up until that point, the executive had agreed that we would keep our schools in Northern Ireland open. We actually did a joint press conference in the Department of Health with all ministers standing behind the podium and agreeing that was the approach. On the 13th of March, the then Deputy First Minister, now First Minister, Michelle O'Neill, went out and announced that she thought schools should close in regards to that. So this was the executive meeting that followed, which had been a unified position, being, I suppose, broken not in regards or in the context of an executive meeting, but also straight to the media.
Thank you. Now, would you agree that even though you plainly query the accuracy and completeness of these notes, that where we see DOH, that refers to you from the Department of Health?
Yes.
Thank you. And so is there any dispute that it's likely you would have been referencing a meeting with Mr Hancock on the Friday and that there have been 1,083 tests with 45 confirmed cases as of the date of this meeting?
That's correct.
Yeah.
But I'm not sure over what time frame that report would have been made at that point.
Thank you. Now, can we go over the page, please? We can see again, by reference to you, contact tracing, need to redeploy resources. And then a little further down, you say, we've got capacity for checking numbers, you said 100 per day. Is that likely to be in the context of the checks that could be done by contact tracers at that time?
That's probably the number of tests, I believe, around that point.
Okay. And then again, we look, then you say this, and prefer to use resource to combat COVID-19 rather than count, self-isolate for 7 days first rather than testing. And I think particularly that summary of what's attributed to you has been something that a number have commented upon about the statement. Do you want to clarify what you said, to the best of your recollection, but what you meant or what you intended by what you were saying?
Again, for a meeting that was 5 years ago, over 5 years ago, my lady, from this hand-written note, I believe what I was referring to there was actually the use of the resources to combat COVID-19. So it was actually using those tests within the healthcare facilities that we referred to earlier on, in regards to ICUs, haematology patients, oncology patients, and also where there was outbreaks within care homes. Because what we had done at that point was actually recommend anyone with symptoms to isolate for 7 days first, rather than seeking a test to confirm that they had actually a positive case for COVID.
Thank you. Now, again, Mr. Swan, I don't mean any disrespect to you, because I'm not going to go to every entry that's attributed to you. So I hope it's not considered that I'm being selective in the entries I take you to. If we can move over the page, please, to page 4. The question was asked as to how many people in the Northern Ireland have COVID, and the response attributed to you is worst case scenario, 80% of population, some no symptoms, some mild, some serious, and then medical system can check figures, I think. And so it appears there that you've recognised and identified as of the 16th of March that it was known that there was an ability for asymptomatic transmission with referencing some no symptoms.
I'm not sure that's actually what has been referenced there in regards to the worst. I think that was coming from the CMO briefing that we'd had previously in regards to the worst case scenario was 80% of the population could have COVID. The fact that some could have no symptoms at that point doesn't necessarily imply that they were asymptomatic in regards to transmission. At that point, it was the case numbers that we could potentially face.
And so then, can I be clear, as of March of 2020, did you have any understanding or knowledge, information provided to you that suggested that someone could be asymptomatic or pre-symptomatic, no symptoms, and be transmitting COVID?
No, I think that established itself as a known fact up until the point of May 2020 was when that was agreed as a possibility and a consequence.
Thank you. Now then, we can see over the page, please, again, we can see there appears to be challenge as well from the DOF. Is that the Department of Finance?
Yeah.
So saying trying to prevent spread, wait for people to present doesn't chime with delaying, better to test more, resourcing issue, discuss more, and then I can't quite read the next bit, more cases we can identify, better we can address. And again, the response attributed to you suggests you were saying self-isolate, containment phase, self-isolate, delay phase. So can you assist us any more about, again, what appears to be others beyond those we've heard in this inquiry, challenging a decision to stop testing?
Well, I'm not sure that was a challenge to stop testing in regards to that. Is waiting, and again, the same difficulties you have in disseminating what it actually does say in regards to some of the comments there. But again, the Department of Finance would have been at that point a Sinn Féin minister in regards to where they were coming from in regards to their point as well.
Thank you. Can we then please again move forward again, appreciating there's many of your entries attributed to you that I'm not taking to. Page 7, please. Can you help with this? We've got what appears to be exec direction query or question mark. I'm following advice of my CMO, spikes clusters, not same here as Republic of Ireland, medical advice, timing's different to Republic of Ireland and GB, and then it seems to be reference to north, south, east, west, and so on. And so can you help at all with the executive direction with the question mark, whether this helps at all with any recollection about what was being discussed?
My lady, in regards to that, I think it reflects back to an early comment in regards to that, and it was that point, if executive ministers had a problem with the direction of travel that we had taken at that point, I think my point was that the executive want to give me a direction to change what we had done in regards to that. Now, I don't think, as I said earlier, there was no recollection of anybody actually doing that. So there was challenges, there was queries in regards to what we were doing, but there was nobody actually coming back and saying, will you go the other way? Can you do something different in regards to the testing capacity? I think I've already covered that a number of times in regards to the capacity that they've actually had. Moving through, timing's different to ROI versus GB. I don't think there was in the early stages in regards to a big differential in regards to the steps that we were taking in regards to that. North, south, east, west, I don't know what that refers to in regards to the other comments as well.
Now, can I look at it from a different perspective? You're saying that the executive weren't asking you to take a different direction.
No, well, they weren't telling me to take a different direction. I referred to earlier on those issues that were cross-cutting can be called in by a minister in regards to that. So there was challenge, there was questioning, there was robust debate around the direction we were taking, but there was no direction from the executive, first or deputy first minister, actually to change course.
Well, again, we've heard evidence from Ms O'Neill today that she was saying just that. We need to be test. We're making a mistake. And the notes reflect that from her perspective when she was taken to them. So their position would be you're the decision maker as the relevant minister, that they are robustly challenging the path of travel that you had taken Northern Ireland on, but notwithstanding their challenge in this meeting that was fraught, that you didn't alter the course.
But in regards to, again, that approach for saying test, just because you say it doesn't mean to say tests will miraculously appear, reagents will appear, swabs will appear, or the machines that were necessary across the labs would suddenly materialise in regards to that. So in regards to the tests that we had, again, as I say, we'd redirected them to the healthcare facilities where we thought they were appropriate to use.
Thank you. Would you agree also, in terms of the difference of accounts linked to the 12th of March, certainly these notes don't suggest at any point, any note to suggest you were saying, well, actually, Baroness Foster, Ms O'Neill, this was dealt with on the 12th of March. So there's certainly no entry to suggest a suggestion that had been decided on the 12th of March. And so why is it being discussed again?
No, but neither is there any reference from the First and Deputy First Minister at that point saying this was agreed on the 12th of March. It's now the 16th. We've had 4 days where they could have stepped in to direct me to do something else or called an executive meeting because they didn't agree with the direction of travel in regards to the decisions that were taken.
Well, on that point, Mr Swan, their evidence is that they had not appreciated that the decision of the 12th of March and moving from contain to delay meant that testing and contact tracing in Northern Ireland was what had been signed up for. The clarity about that came in the meeting on the 16th of March when they would say they were challenging the decision to stop testing and contact tracing.
But in regards, and it goes back to the minute of that Cobra meeting where it says to stop testing and tracing in all geographical areas. So again, it goes back to that point in regards to what their understanding of what was agreed to, what was discussed at that Cobra meeting in reflection. And again, maybe it is in regards to future pandemics, a recommendation is that officials who attend those meetings actually come back with that detailed breakdown so that all who are attending the meeting, even if it is, the meeting on the 2nd of March was the first that they had attended. So there's a catch-up or an official briefing in regards to what it actually means going into the meeting, but also after what it means coming out of the meeting.
Can I just say, Mr. Cartman, my notes suggest that Baroness Foster didn't say she said test. She said that at the meeting there were those who challenged the minister on the decision to cease pausing.
My lady,
Certainly
you're entirely right. The test is attributed to Michelle
O'Neill.
Michelle O'Neill, thank you. Can I then, please, I'm not going to go through all the other entries, but can I just briefly take you then to page 31, and then I'll allow you an opportunity to say anything else about this meeting and the approach. But again, we've another example here of the Deputy First Minister, which is recorded as saying the approach is fundamentally flawed. The WHO says test and test again. We're not doing this. Your response then seemed to be that we don't have capability. The Department of Finance said there was a resource issue. And then we see, is it the Department of Justice giving a contribution? And so, again, in terms of what appears to be capturing the Deputy First Minister certainly saying what we're doing is fundamentally flawed.
But I think that is what she is saying. But her approach for test and test again, we're not doing that. That's correct, because we didn't have the capacity to test and test again. So it's putting into context what tests were available at that stage, where we were using them compared to where we were, January 21, where with LFTs and lateral flow devices, where we were able to test. So it's a matter of perception in regards to that. Look, also at that point in time, the Deputy First Minister was been highly critical of all my responses in regards to how we were combating COVID-19 in regards to that.
Thank you. Mr Swan, out of fairness in terms of the resolution that will have to be made of these issues, is there anything else that you want to say from your perspective about the meeting of the 16th of March and the position then to continue as part of the delay phase not to test the community testing and not to continue with the contact tracing until it came back on again at the end of April?
Well, I think, my lady, in regards to if we'd have kept community testing without being able to follow up with an effective contact tracing programme at that point, I could be legally sitting challenged here today as why we actually weren't using those tests within hospital, care home and care facilities in regards to ICU as to how we were actually using them as well. So it's a challenging position in regards to that. If we had had the capacity and the number of tests at the start, certainly the approach of test and test again is the right one if you have the tests.
Thank you. Can we then please, just to give a context as to the position in Northern Ireland, please, if we can look at the situation report for the 12th of March, please, which is INQ 83097, please. That's INQ 83097. Thank you. We can move to the next page again. If we look for Northern Ireland as the position as of 11th of March, just 20 cases, would you agree?
Yeah.
Thank you. Then if we can move into, again, just to have an understanding about how the testing was increasing, your April testing strategy, please, which is INQ 103649, please. Now, this is, as we can see, your testing strategy of the 6th of April 2020. And if we move into this document, please, to page 12, that if we look at paragraph 3.3, we can see that testing had been scaled up from 40 tests per day in January 2020, and the current testing capacity is up to 736 tests per day. The factors influencing the number of tests carried out each day depends on the number of swabs received, availability of testing reagents and testing kits. And so would you agree, Mr Swan, that the numbers of tests being available with the steps, particularly with the input of the academic consortium, was increasing the availability in Northern Ireland?
Yes, and that was the intention of it, but there were those limiting factors in regards to, as I state there, the availability of testing reagent and also the kits as well, because we were at the end of a very long supply chain in regards to a number of these reagents and testing kits as well, which were swabs which were easily available and easily purchasable from China, and just-in-time supply chains all of a sudden became high demand across the world in regards to that.
Thank you. The start of this section, I just want to make sure there's absolute clarity. It's described within your strategy document as scaling of nucleic acid testing. it's right, isn't it? When you're talking about that, that's essentially the PCR because
yes.
it's the ribonucleic acid in the PCR test. Thank
Yeah.
you. And was there any reason why you were describing it as the nucleic acid testing rather than the PCR testing?
I'm not aware why there have been any change of names in regards to that and that.
Thank you. Can we then move forward again just to get a snapshot of how scaling up happened in Northern Ireland, and then move please to your 20th of May testing strategy update, which is INQ 103650. Thank you. And again, if we move into page 3, but internal page 2, please, again, we get an idea of the testing. Thank you. We can see you've identified since publication of our strategy, we've increased our testing capacity significantly at the beginning of this pandemic. HSC laboratories were processing 40 tests per day. The figure has now increased to 1,700 tests per day in our HSC laboratories, with an additional 800 tests per day under the national initiative. And I'm confident that we will continue to increase our testing capability and capacity to ensure we continue to deliver a robust response to this unprecedented pandemic. And so again, would you agree these are helpful for identifying how testing was increasing?
And again, the work across, I think, all sectors in regards to how we were scaling up in partnership with others.
Thank you. And can we then move, please, into page 19 of this document? And it's a helpful document because there's lots of graphs that identify the improvements and the increases, but we can certainly see estimated daily testing capacity by testing platforms that was anticipated for the next period of time from the May to the June. And can I ask you just to assist us? On the left-hand side, we've got a number of breakdowns, and obviously the shading is not helpful, but can we just, so we understand the practicalities of the equipment, the first, the C-Gene, which testing platform was that? Was that the one operating in the hospitals or in the...
I honestly can't comment in regards to where they were actually positioned in regards to our different labs, but the first 4 would be within our health estate in regards to that, and the 2 bottom ones, as you can see, is the Allmac partnership and the AFB partnership in regards to those. So,
thank you. Thank you. And then I think we know on the timeline, if we move forward, please, to 120704. That's 120704. Thank you. The test, trace and protect strategy of the 27th of May was introduced when all the 4 nations essentially by then had identified their strategy. And thank you. We can turn into page 9 of this document, please. Again, this helpfully identifies that the PHA had reintroduced the contact tracing in the April, and from the 18th of May, they had been contact tracing all confirmed cases. And over the page, this is likely to become a part of everyday life. Thank you. Now, thank you, that can be taken down. And so, Mr. Swan, looking at what was possible if a decision was made on the 16th of March to not follow the decision to stop testing and contact tracing, would you agree that there was an option to have a different approach in Northern Ireland that could have assisted in stopping transmission of COVID?
but I think to take that different approach, as I've said earlier, would actually been to use those tests not in healthcare facilities in regards to where we currently were and where we were actually using them at that point in time. So was it a decision to redirect those tests within healthcare facilities and increase the numbers we were actually using there, or continue to use the contact tracing position that wasn't robust enough actually to stand up at that point?
Now, on the decision to stop contact tracing, the statement that's been referenced of Dr. McLean from the PHA indicates that the PHA also were not involved in discussions about the decision to stop contact tracing in March of 2020. Do you agree with that position?
As far as I'm aware, but I think I've also seen a statement from Dr. McLean in the PHA where she goes on to say that neither did they then challenge it with the Department of Health or the executive as well.
Thank you. Now, can we then please look at an issue of public communication, because I think your statement helpfully identifies how the other testing strategies increased in Northern Ireland in the testing centres. But before doing that, can I just deal with very briefly, your April strategy identified the use of LAMPOR testing. And can you just give us a bit more evidence? Because obviously Northern Ireland was quite unique for trialling the LAMP testing from April of 2020, which is right, is it? That's where you can test for COVID through saliva, sort of a spit test almost.
It's a very specific test in regards to that, not a large scale one as well, but we used a pilot of it because we could use it in specific facilities. We used it in a number of special schools, milady, where we were, seeing that increased challenge in regards to how we were able to test. We also used it in a number of health facilities where, especially, I think residents with dementia had quite an adverse reaction to the physical swab. So again, it was a small scale test in regard, or a small capacity that we had, but we saw advantage in using it as a pilot, especially in those special needs schools, and to enable those people who were uncomfortable or either just physically couldn't do the swabbing, where we could use that saliva test. Basically a precursor for LFDs, only in I think the turnaround time was a 20-minute result at that point as well. So when there was the advantage, and again, I think that was the strength of having the academic consortium. So when the pilots like that appeared, we made sure we took full facility and full use of them and made sure they were used in a targeted approach.
Thank you. And was that LAMP testing taking place in Northern Ireland, or was that done through Oxford University?
It was done in the facilities itself was actually on-site facilities as well, so you were able to do it within those special schools, within those geographical settings as well, but we were part of that wider pilot.
So can I just be clear, where did the LAMP machinery, my understanding is to do LAMP testing, it's actually very cumbersome machines that enable you to process the test.
And that's why it was small scale, so we were able to do that, within Northern Ireland. My understanding, milady, I'll check with the CMO in regards to that, but we were part of that pilot. I assume we had the facility. Okay,
thank you. Well, I won't press you further about that. Thank you. Can I then just be clear about, we know that you got when the Lighthouse laboratories went online, can you just help, so we're absolutely clear, what access to testing were you able to utilise of the Lighthouse laboratories?
The Lighthouse laboratories, the contract, again, as I said earlier on, was between DHSC and Randox and those Lighthouse suppliers. Our agreement, and it was the memorandum of understanding signed across all four nations, was actually we got our Barnett consequential of the capacity, which was 2.85% of the available overall testing capacity in regards to that. But on special occasions, and I suppose with special representation, we were able to ask for additional resource in regards to that as well, should we need it, or should we see specific spots where we needed to do additional testing. What we did in Northern Ireland in regards to those, we had the regional facilities that were permanently set up with a large number of tests available. We had local facilities which were permanently there but with a smaller number, and then with mobile testing units which we could deploy to different areas, different facilities, to make testing, I suppose, geographically accessible and physically accessible as possible.
Thank you. And so did that mean that the PCR tests were being shipped off from Northern Ireland to England?
Well, no, because of the Randox, or the facility that we were able to use, so the samples that were being taken were being tested, so it was the Lighthouse facility. Yeah.
So you're describing Randox as part of the Lighthouse
Yep.
facility. Thank you. And then can I, very briefly then, just to deal with an accessibility or issue relating to these tests, INQ 373440, and I think this is the 8th of September 2020, where you had contacted Mr. Hancock by reference to issues facing the national COVID-19 testing system, where it appears that when people were seeking to book tests, they were being offered tests in the United Kingdom rather than in Northern
Yeah.
Ireland?
Milady, again, that was, I suppose, one of the geographical challenges of Northern Ireland, and the speed of the system was actually set up in regards to that. So people, when they put in their postcode, were directed to their closest available test and test facility. In some cases, because there's only 14 miles between us and Scotland, some people were actually being directed to Scotland to go for a COVID test. So when the system had been set up, that particular peculiarity of the Irish Sea hadn't been taken into consideration. It caused some significant concern in regards. It became a media issue over that specific weekend in regards to that. So it was something we were able to resolve as well.
Thank you. For my purposes, Mr. Swan, I have 2 short topics left, please, if you can assist me. And the next topic is public communication. Can we please display your paragraph 231 at page 72? Thank you. Thank you. Now, you detail that the Public Health Agency established targeted communications aimed at ethnic minority groups and also communities where individuals live in cramped accommodation. You specifically recall that this work was undertaken by PHA. Can you assist to what extent the Department of Health was involved in this?
We were part that was undertaken by the Contact Tracing Steering Group. The department had representation on that as well, along with Business Service Organisation, Patient Client Council, the Ulster University, Queen's University, but also NICFA, which is the Northern Ireland Community and Voluntary Associations as well. So under PHA's remit, they were able to do that. That Contact Tracing Steering Group also engaged through their preparation for that work with the commissioners in Northern Ireland, so with their Older People's Commissioner or Children's Commissioner as well in regards to that.
Thank you. We can then go backwards, actually, apologies, 223 on page 69. Thank you. You note that you're aware of the potentially disproportionate impact of the pandemic, including isolation restrictions on certain socio-economic groups and ethnic minorities. Can you recall at what stage you became aware of the disproportionate impact of the pandemic on the ethnic minority group specifically?
In regards to specifically, it wouldn't have been that early on in regards to Northern Ireland specific. It was the work that I suppose Dr. Chada was doing with the Inter-Ethnic Forum across all health care systems across the United Kingdom in regards to what was actually being seen in regards to that. In Northern Ireland, in regards to the social economic groups, I think the biggest, I think the positive step because of that cross-cutting nature was actually those discretionary payments that the Department of Communities working with ourselves were able to bring in at the start as well.
Thank you. And is that the discretionary scheme that was available for isolation payments from was it the 25th of March?
25th of March. So I think Northern Ireland was the first of the 4 nations actually to introduce that payment and that support mechanism as well, which I think, I recall, my lady, I think came up to a sum of £4 million during the duration of the pandemic, but it was something that we saw was necessary, and again working in partnership with the Department of Communities we were able to facilitate.
Thank you. Can we then move to the next paragraph, 224, please? You recall that the Public Health Agency commissioned reviews that considered the impact of the pandemic, including isolation, and that evidence on inequalities from these reviews was shared with your department and subsequently used to inform policy. How were these reviews used to shape policy, and what was the disproportionate impact of isolation on minority ethnic groups considered at this stage, please?
Well, in regards to the inequality, that Health Intelligence Unit, it also identified those the harder to reach groups across Northern Ireland, including our ethnic minorities, but also our aged population and rural population as well, my lady. One of the challenges that we've had, and we've addressed it, and I think the work that does need done in Northern Ireland is actually the identification through our health records of our ethnic minorities in regards to that, not just those who work in the health service, but also who are part of our greater society as well. In earlier modules, we've referenced the Encompass programme, which is brought in, which is a single health record that will be available, is available now across all 5 of our geographical trusts. So that'll start to feed in to how that data is actually collected and utilised.
Thank you. Could we next move, please, to your paragraph 127A on page 42, please? I think to understand paragraph 127A, we just need to briefly look at, this is a time around prioritisation and eligibility for lateral flow devices, which we know came on the end of 2021, and certainly you're suggesting January 2022 here. You say, at the time I agreed this change in the guidance, I considered it was clear. However, 5 years on and no longer as immersed in the pandemic response as I was then, I can appreciate at the times the fast-changing nature of advice and guidance may have been challenging for some members of the general public. The Department made significant efforts to provide clear communications to accompany policy changes. Clear communication advice will be critical once again in any future pandemic response, and I believe that recommendations and lessons learned from the inquiry will be particularly important in this regard. Are there any particular further lessons or recommendations you would wish to bring to the inquiry's attention?
Well, my lady, in regards to, I suppose, building on this, and it is about communication in regards to clarity and understanding. While we change, our interim testing protocol as well, with 10 iterations in Northern Ireland over the period of the pandemic, we understood, and working closely with the system, what it would change, what it meant. But in regards to making sure that there's a clarity of understanding, and I think at times especially useful in regards to the interaction with our Children's Commissioner in Northern Ireland, who was a very strong advocate of making sure language being used was as simple and as understandable as possible. So I think in regards to future productions of policies, strategies, that is something that should be very clearly embedded in regards to steps that should be taken. In regards to wider recommendations, I think my concern is the scalability of our laboratories in Northern Ireland was only possible because of the partnership working that was established in the heat of a pandemic. I would like to see that strengthened, maintained, and made more robust. The concerns that I have, like lighthouse facilities, already we're seeing actually closed down across the United Kingdom, because I think it was Mark Drakeford who actually said in regards to his evidence as well, it's hard for politicians to sustain the investment in large-scale testing facilities and infrastructures in case it may be needed. But I think there has to be that watching brief across all four nations working in partnership as to how, if, and I sincerely hope it's never needed again, but should that large-scale laboratory system be ever need to be utilised, that there is ability to switch it on. Should not also be in terms of physical capacity, but also in the workforce as well, so that there is a collaborative puzzle. There's a memory muscle there as well as to how it was done, when it was done, and what steps were taken. Referring that specifically back to Northern Ireland would be part of my concern. Many of the senior medics and professionals that we relied upon came back out of retirement or from other parts of service simply because of their dedication to the Northern Ireland Health Service, but also the personal relationship, I believe, with their Chief Medical Officer. When he asked, they answered the call in regards to that. So I'm concerned, 5-10 years down the time, will we have that professional capacity in reserve, in standby, whose experience can be actually called on and utilised?
Thank you. You've given a great deal of reflection there to her ladyship. We've also got paragraph 99 to 100, where you've given further personal reflections as well on earlier pages of other reflections. But can I just finally, for my purposes, ask one question? Paragraph 310 on page 99. Thank you, that's paragraph 310, page 99. And can I ask you, you're referencing there the use of the COVID-19 proximity app. We know that Northern Ireland developed and got their proximity app out first. Do you have any reflections on the fact that essentially yourself in Northern Ireland and Scotland were using different app than was then not the COVID-19 app that was then deployed from the end of September in England and Wales?
Well, I think part of that, my lady, and I really don't want to take away the fact that our digital communications information officer and his small team were actually able to produce a COVID-19 proximity app in Northern Ireland, considering the size and the ability that we have. It was the first international cross-border app that was developed across the United Kingdom. We were the first actually to deploy a COVID-19 proximity app out of the 5 nations as well. In regard to that, we had a successful uptake, I think, and complete over the duration and the period of time. 6,700 people actually downloaded the proximity app in Northern Ireland, which out of a population of 1.9 million is actually, I think, a very positive story. But it goes back to some of the communications we had around building up to it. We were very clear that our app wouldn't be there to capture data, it wouldn't hold any personal information. And again, that was because of that interaction working with the Children's Commissioner, the Information Commissioner, and all in regards to that as to how we developed it. So we moved at pace in regards to the operation with the other apps. It eventually was interoperable with those apps as well over a period of time. But I don't think it had been right that we waited in regards to them developing our app to make sure that it worked with them. What we were able to do was work with the Republic of Ireland in regards to making sure that cross-border mechanism actually worked. I think it was the first international cross-border app that there was developed around the world using that platform. So it wasn't the fact that our platform didn't work with the English one. I think it was the English one didn't work with ours. In regards to that, they were able to adapt, the care app that they already had.
Thank you. Mr Swan, those are my questions. My lady, there are core participant questions.
Mr Thomas. Mr Thomas is that way.
Yeah.
Good afternoon, Mr Swan. Just a couple of questions, if I may. I should introduce myself. Leslie Thomas. I represent FEMHO, Federation of Ethnic Minority Healthcare Organisations. At paragraph 255 of your statement, you say that it was not possible to analyse trends relating to ethnicity due to poor coding of ethnicity in healthcare records, as routine data flows did not allow the identification of trends in the transmission and infection rates of COVID-19 for different ethnic backgrounds. Question: can you explain how this lack of data disaggregated by ethnicity impacted on policy decisions?
It was the fact that that data wasn't collected in regards to your health records in Northern Ireland, as I referred to in an earlier answer. The development of the Encompass digital record now asks for ethnicity and I think first language and country of origin as well. So one of the learnings, not just coming out of an earlier module, but the deficiencies within our previous healthcare system was that data was not recorded.
Yeah. And just following on from that, what strategic and policy outcomes could have been potentially achieved which were undermined by this lack of data?
I don't think there was any, in regards to that lack of data, when we talked earlier on in regards to the work of the PHA and the guidance that it actually put out. It put out its guidance how to access testing and later vaccination in a number of actually ethnic languages, from Timorese through to a number of other languages in Northern Ireland. Because of our food sector, we have quite a number of ethnic groups within Northern Ireland. So in regards to those policy decisions, because we didn't have that health data by ethnicity, it made it challenging for us to do that. I do hope, and that's why when I was Health Minister, I saw the benefit of Encompass in regards to rolling out that single health record across Northern Ireland so that everybody accessing our health service has that ability built into it, but also that centrally the department, the PHA and others have the ability to follow that through to make sure those weaknesses don't present themselves again.
Thank you, Mr Swan. Thank you, my lady.
Thank you, Mr Thomas. And Mr Wilcock, who's just there.
Good afternoon, Mr Swan. As you know, I represent Northern Ireland COVID bereaved Families for Justice, and I've been granted permission to question you on 4 separate topics, none of which you've been asked about so far. Topic 1. According to your statement at paragraph 48, you cannot now recall receiving information on the pre-pandemic capacity of the existing laboratories testing capabilities in Northern Ireland. When your then Permanent Secretary for the Department of Health gave evidence in Belfast this time last year, he stated that, quote, by any measure, Northern Ireland had a low testing capacity in February-March 2020. Does it follow that you never discussed the issue of the pre-pandemic capacity of Northern Ireland's existing laboratories with your Permanent Secretary after you took office on the 11th of January 2020?
Again, I think in an earlier answer, my lady, I spoke about the pathology review that had been started in 2016. It went out to public consultation in 2017 and then was commenced under 2020 as well. So there's work being done in regards to that within the department about actually development of laboratories in Northern Ireland. So that in that context, it was about how we brought about that a single electronic recording system, LIMS, so that is actually interoperable with Encompass as well, but bringing those, rather than those labs being under the 5 trust structures, they were brought under one single structure as well. So the capacity as to the number of testing machines or platforms, I don't recall being mentioned at that level at that stage, but there was about the structural review of our laboratories.
So is your answer yes, I didn't speak to Mr Pengali, but work was going on nevertheless?
There was work going on, and not every conversation I had in regards to every structure, every statement, every strategy was with the Permanent Secretary.
Topic 2, Public Health Agency. In your statement, you state that you, quote, consider that the collaborative way in which the department and the PHA worked together throughout the pandemic in delivering the Test, Trace and Isolate programme significantly helped meeting the unprecedented demands of the pandemic and helped make the most of available experience, skills and expertise. This close joint working, you believe, had a positive impact in Northern Ireland. Can I ask you 4 questions on that statement? 1. Whilst it's clear that the Department of Health and the PHA did work together in delivering Test, Trace and Isolate and Protect, do you accept that, as we heard in Module M2C, the relationship was not without its tensions?
The relationship, I don't think, was without its tensions, my lady, but that isn't in opposites to the fact that we weren't or couldn't work closely together in regards to what needed done and indeed what was done.
So what impact, if any, did those tensions have on the delivery of Test, Trace and Isolate policy in Northern Ireland?
I'm not sure that, well, first of all, I'm not sure specifically as to what tensions or where within the system or when you're referring to, but I'm not aware during my time as Minister that those tensions, or if what was referred to as tensions, actually had any impact on the delivery of Test, Trace and Isolate.
When you gave evidence in M2C, for example, you stated that the Public Health Agency was, quote, not in a robust enough situation to scale up as was necessary. That's one of the tensions that we were talking about. Was that one of the reasons why in late 2020 your department commissioned a rapid, focused external review of the Public Health Agency for Northern Ireland's resource requirements in response to the pandemic over the next 18 to 24 months?
But I think the assertion of the assessment of PHA at that point in time, my lady, isn't a tension. It was my perception at that stage that it wasn't in a fit state, and I think there was previous...
That's not a tension, thinking something... The operational body is not in a fit state.
Sorry, it never presented itself as a tension with any conversations I had with the chair of the PHA. It was my impression at that stage. Doesn't mean to say if you have an assessment of something being in that state that it necessarily produces a tension. I don't think there was any counter in regards to those conversations at that time in regards to how that relationship worked. I think when you actually look at some of the board and some of the interactions that were set up, there was that good working relationship. between the organisations and themselves. And as Minister, my lady, I set up a regular interface with the chairs on meetings of all my arm's length bodies, and it's not something that I ever recall the chair of the PHA raising with me. In regards to the review that was brought about at that point in time was actually commissioned by, I think it was Professor Ruth Hussey, who was a former Chief Medical Officer from Scotland, and what that was to assist working in partnership with the PHA board in regards to making sure that they were as robust and as ready as they could be for the next 18 months following what had been a very challenging time.
In fact, the review confirmed, didn't it, that among the structural weaknesses that the PHA had to contend with in carrying out its test and trace functions were the fact that it had, and I quote, had temporary leadership arrangements for some years, a new interim CEO and a new Director of Public Health came into post, I'm quoting from the review, as the first wave of the pandemic took hold. They faced a substantial challenge to pick up the reins of the organisation at such a crucial time. And when the organisation had to embrace remote working at speed whilst mounting an effective response, there were vacancies in senior posts. The health improvement function, for example, had 46% of its staff in temporary posts as a result of delays to approval mechanisms at regional level. Report goes on to refer to the initial service being extremely stretched by demand, insufficient project management. None of this is to criticise the efforts that the PHA made, but the fact was it was starting well behind the starting line, wasn't it?
Yes, and that's where my original statement, I think the first quote that you actually gave was the reflection from that, but it was also, my lady, the work that then came out and the recommendations that came out from that Hussey review to reshape and refresh the PHA in regards to that. And I think one of the recommendations, and I know we'll talk about that, change in leadership, but all organisations go through change in leadership at various stages.
Topic 3. This is partly in the context of the meeting you've been asked so much about the 16th of March 2020. In your statement to the inquiry, you state at paragraph 16 that you, as the Minister of Health, set the overall course of the TTI programme, you approved strategy and policy decisions, and that while you, and I quote from your statement, regularly updated the Executive on delivery of the programme and policy changes, with a few exceptions, the Executive was generally asked to note the changes. Do you agree that the few exceptions that you refer to all post-date August 2021?
I don't remember each of those papers in detail as to whether they finished to note or to approve or what direction was taken at that stage. But I think it goes back to, again, the earlier answer, but those issues that were cross-cutting and controversial, or those issues that were actually cross-cutting, or those where I felt the need and the ability to update the Executive as to the steps that we were taking.
Well, I don't want to repeat the various arguments either way. We've been through those at length. Can I just ask you this? In retrospect, do you accept that it might have been better for you and the First Ministers and the Executive to have worked in a more collaborative and transparent way at the outset of the pandemic?
I think, my lady, I think this has been covered in M2C and earlier in regards to this, the challenges of working across a 5-party mandatory coalition weren't without its challenges, especially during the period of a pandemic. In a transparent way, I know that I appreciate your comments in regards to that. My lady, I think one of the criticisms that wasn't levelled in regards to any of our executive meetings was a lack of transparency, because I think it was covered widely in M2C, was the fact that those meetings were often directly leaked to media as they were having, as well as we were having those conversations.
Well, I think you know very well, don't you? I'm not referring to that as transparency.
Right. Well, no,
transparency within the Executive.
No, I think there was a level of engagement, and I'm sorry, that's what I took as transparency in regards to that comment, in regards to the wider point. But I think in regards to that communication within our Executive, I think it was healthy, it was robust, but it was also part of that challenge that we have in Northern Ireland of a 5-party coalition.
Which we understand. Thank you. Topic 4. This is to do with targeting of testing. In your statement to the inquiry, you point out that after March 2020, testing was primarily targeted in clinical care of the sickest individuals, requiring inpatient care, protecting those caring for them, and in the management of outbreaks, for example, in care homes. Now, Professor Arden has provided an expert report to the inquiry, pointing out that policies prioritising certain groups, such as testing for NHS staff and patients, early on in the pandemic, may have had implications for other groups, including vulnerable people in the community. Do you agree with Professor Arden?
I think it goes back to the abilities. If you look at the interim testing protocols that I referred to earlier on, Milady, about 10 of them throughout the duration of the pandemic, it was about the utilisation of the capacity that we had. As Health Minister, if we'd have been able to start in March 2020 at the point in regards to testing that we finished with LFDs, it would have been a very different picture. It's something I wish we'd been able to do far quicker in regards to that. I think it was in regards to LFDs first come available at the end of that year. I asked for 4 million from Matt Hancock and I got them in regards to that because I valued the ability for testing, but it's also that testing of those people in those critical care facilities as well.
In terms of the knock-on implications, this inquiry has heard evidence from one of my clients who you know, Hazel Gray, who contacted you in December 2020 about the fact that her wheelchair-bound mother's home carers were never tested because of the policy of their employers, the Western Trust Home Care, and that this had more than likely led to her 80-year-old father contracting COVID and being taken to hospital, given that he rarely left the house. She described in the text messages that she exchanged with you, this is a major flaw in the system. Sadly, as I believe you know, both Mrs. Gray's parents died shortly afterwards. Do you agree that her description of what she'd been told as a major flaw was in fact an understatement?
Well, in regards to the testing of all healthcare workers and getting through those protocols, Milady, it was regards to where we could get testing in regards to facilities. In regards to Mrs. Gray, I do want to pass on publicly my sympathies to her and her family in regards to the trials that she went through at that stage. I do know from reading her statement and also listening to her commentary both in the impact video but also media reports back home of the challenges that presented and also the report and the response that the Western Trust has gave to her in regards to that. So it goes back to that point of symptomatic and asymptomatic healthcare workers testing. My lady, if I had had the ability to test everyone regularly when they wanted it as they required it, I can assure you, my lady, and this inquiry and the members that the council represents that I would have been doing that from the very beginning.
But the world is as was rather than what we wish it to be.
Right.
Do you agree that, in fact, her statement of what happened was much more than a major flaw?
Well, look, in regards to the loss of a parent, especially in regards to the loss of two parents from this pandemic, my lady, when we look at the number of lives lost across this United Kingdom and indeed across the world, the flaws that were there, the challenges that have been made, and hopefully the recommendations that come out of this inquiry make sure that that sort of a case and occasion never arises again.
My lady, there are all the questions I wish to ask.
Thank you very much indeed, Mr. Wilcock. Mr. Swan, that completes our questions we have for you today. The pressure on health ministers was extraordinary. Did you ever question why you didn't go in the opposite direction when your party suggested you took on health in January 2020?
My lady, I have many times, and I come back to that, and I don't want to make light of anything that we've been through today. When I said with those two choices, I was former president of the Ulster Young Farmers Clubs of Ulster. The two departments that were left were health and agriculture. And there is many a reflection. I wonder when we look back now 5 years on, if I'd have been health minister rather than agriculture, how things could have changed differently. But my lady, I hope the input that I was able to make as health minister made some positive difference in regards to how we responded in Northern Ireland. I think it was fortunate to have a very dedicated healthcare professionals around me working in health and social care, but also at a departmental level, PHA level, and all those other organisations who were providing input at what was a very challenging time.
Well, Mr. Ryan, I don't know if you heard what I said to Professor McBride, but whatever criticisms people may have to make of the system, no one doubts the commitment and dedication that people like you, and indeed the Professor, put into responding to the pandemic. So thank you very much for all that you did then. Thank you for your help with the inquiry, and I know for a fact that we haven't ended the burden on you. So thank you for the help that you'll also be giving, I think, again in July.
Yeah, I think so, Melanie.
Well, thank you very much. We shall end there, and I shall return 10 o'clock tomorrow.
Thank you, my lady.